Good morning, good afternoon, and good evening. Thank you for joining the Wilson Center's Maternal Health Initiative along with UNFPA and the International Confederation of Midwives for a panel discussion on Indigenous midwifery. I'm Sarah Barnes, and I direct the Maternal Health Initiative at the Wilson Center in Washington, D.C. For those of you who are not familiar, the Wilson Center is a critical source of nonpartisan foreign policy research and analyses and serves the vital role of linking Washington to the world. The Maternal Health Initiative is one of several thematic programs at the center, and we focus on decreasing maternal deaths as well as issues related to global health and gender equity. 2020 is the year of the midwife and the nurse. And this event is part of our Year of the Midwife series, made possible through the generous support from UNFPA. Globally, Indigenous women and adolescent girls experience significantly worse maternal health outcomes than non-Indigenous people. For example, in the United States, the risk of maternal death is twice as high for Indigenous women as it is for white women. And in Australia, the risk is 4.5 times higher for Indigenous women than their white counterparts. Worldwide, maternity services and health policies predominantly reflect contemporary Western medical values rather than Indigenous worldviews. Culturally appropriate care providers and culturally appropriate models of care can contribute to addressing the vast health disparities between Indigenous and non-Indigenous people. Indigenous midwives play a critical role in building healthy and safe Indigenous communities across the globe. According to the World Health Organization, well-trained midwives can provide 87% of sexual, reproductive, and maternal health services. In midwifery care that includes family planning could avert 83% of maternal deaths, stillbirths, and newborn deaths. Making Indigenous midwifery more accessible means that Indigenous women would benefit from midwife-led continuity of care through pregnancy, birth, and the postpartum period. Today, we have an eminent panel of Indigenous midwives from Canada, Mexico, and New Zealand to speak to the varying impacts of past and present maternal health service policies and health systems on Indigenous mothers and families, and to share country-specific strategies used to enhance Indigenous midwifery care in the midwifery workforce, as well as examples of successes and challenges towards improved Indigenous maternity care. Before we begin, I'd like to take a moment to thank our panelists and our moderator for the commitment and time you've put towards this event. We are truly working across time as everyone on this panel sits in a different country in a different time zone. I would also like to thank UNFPA for their support and the International Confederation of Midwives for co-sponsoring this event. Many people and organizations came together to make this event a reality. I'd like to give a special shout out to both the White Ribbon Alliance and the MacArthur Foundation Mexico. Thank you both very much. For today's event, we're using a translator for our panelist from Mexico, Ofelia Perez. Our translator is Irma Blanco, the Executive Director of the IBQ Group in Mexico. Thank you both for the opportunity to collaborate on this event. And finally, thank you to my MHI colleagues and our great Wilson Center AV team for working so hard on this logistically inspired event. Before I introduce our moderator and hand the event to her, I want to remind our audience that there will be an audience-led Q&A following the panelist discussion. Please submit questions to mhi@wilsoncenter.org. My colleagues and I will review the questions and share them during the Q&A session. Again, it's MHI, like Maternal Health Initiative, but it's mhi@wilsoncenter.org, and this address is also listed on your invitation. Now, it is my pleasure to introduce today's moderator, Sandra Oyarzo Torres. Sandra is the Vice President of the International Confederation of Midwives, the first Latin American woman to serve in this role. Sandra has been a midwife for 28 years and has dedicated herself to primary health care in universal health coverage in Latin America, where she is currently the Vice President of the Chilean Midwives Association. Sandra is also an associate professor in the Faculty of Medicine within the Department of Education and Health Science at the University of Chile. Thank you, Sandra, for being here today. The floor is yours.
Thanks so much, Sarah. First of all, I really want to say that I really feel honored today and really privileged to be here, to be sharing this really nice conversation that we're going to have today about Indigenous midwifery. And of course, to feel really honored because it's a really important opportunity for all of us to be together, you know, and discuss about all this special and important topic. But first of all, I really want to say also that I feel honored to be here representing the International Confederation of Midwives. And for ones that do not know about it, ICM is a non-governmental organization representing midwives and midwifery organizations worldwide to achieve common goals in the care of mother and newborns. And how do we do it? We support, represent, and work to strengthen midwifery associations around the world. And it's a very nice work because in that way we really get close to midwives, and of course, women get the best care from midwives. And actually, you know, right now, currently, we are about 143 member associations representing 124 countries around the world. And in my case, for me, it's a really honor to be one of the first Latin American women to be in this position. So I really understand what it means a long way. For us in South America, after 193 years of having midwives associations, is the first time that Latin American women, part of an association of Latin American women that speak Spanish, of course, is part of the organization at this level. So we are really, really feel honored, and I really think, you know, that this is really important. And when we talk with our panelists, this maybe is gonna also be really similar to what it means, the midwifery, you know, the indigenous midwifery. So really I have to highlight how important is that we talked about indigenous midwifery, how important is to learn from indigenous midwives, because we have to really think, you know, what it means. What is the background of indigenous midwifery? Indigenous midwifery is been as a result of colonization and ongoing systematic racism within healthcare systems. Indigenous midwifery services have been drastically reduced and compromised. This has had a devastating impact both on the preservation of culture, on maternal and newborn health outcomes in indigenous communities. So this is really important for us to reflect. In one way, we have moved forward, you know, with midwifery and training midwives. But of course, on the other hand, we also have indigenous midwifery being, you know, stopped from going on. And that means that women at the local level, you know, at the community level, sometimes, you know, they're really close to indigenous midwives. But of course, we have to think, what do we really need to work together? And this is maybe what we're going to talk about today. What do we need to support each other, from non-indigenous midwives to indigenous midwives, and, you know, to really move forward in this movement that takes us all as women, you know, as we know right now. So for this really nice talk that we're going to have today, and really, and start thanking also our ancestors that I'm sure they're here today, because we are here because we had so many ancestors back, you know, so many midwives. The first one, the indigenous midwives in our countries, the mothers, you know, the ancestors, that of course are so happy to have us here today. So I feel really honored to introduce today in this panel 3 amazing women, you know, that are going to be talking with us. First of all, I want to introduce Claire Diane Fletcher. Claire Diane Fletcher is a Potawatomi, Lenape, and mixed settle registered midwives practicing in Toronto, Ontario. Claire is the co-chair of the National Aboriginal Council of Midwives and is an assistant professor in the midwifery education program at Ryerson University. Claire is dedicated to the growth of Indigenous midwifery Canada and the expansion of Indigenous midwifery education. We will also have in this panel, Nicole. Nicole Pihema is the current and first Maori president of the New Zealand College of Midwives. She's the lead of the maternity care midwifery in the Bay of Islands, a mentor of midwifery first year of practice, and a member of the Na Manukura Aopopo, and a governance leadership group, and also she's a representative for the Rural Health Alliance of New Zealand. Is a competence reviewer for the Midwifery Council of New Zealand, and also she's a member of the college's mediation and co-design teams. And lastly, we also have in this panel, Ofelia Perez-Ruiz. Ofelia Perez-Ruiz is an Indigenous midwife with 21 years of experience. She's currently the spokesperson for the movement of traditional midwives of Chiapas, Flor de Maíz. In the state of Chiapas, for 15 years, she has been part of the civil organization Formación y Capacitación, and she's also the founder of civil organizations Camati, Mujeres Construyendo Desde Abajo, Women Building from Below. So we're really going to have an amazing conversation, and because of that, I want to start, with each one of you to have, your first reflections about, to start our panel about, talking about three special issues or two special aspects. First, what do you think is the meaning of Indigenous midwifery in your region, for you, for your families? If you can tell us about a little bit, how is in your country, how is in your community, the Indigenous midwifery? And of course, if you think about the main obstacles and challenges, and of course, successes that you've had in your country regarding Indigenous midwifery. So these three main aspects to reflect. We're gonna have 5 minutes, each of us, each of you, to talk about this. Of course, we feel like we are in our homes because we are. So just relax and let's talk about it. So let's start with Claire. Claire, please, can you tell us about these three questions?
First, I just wanted to start by saying Anashik, which is thank you in my language. So Anashik for inviting me and us all to this panel. And I'm really looking forward to chatting this afternoon about these really important issues. And I thought I'd kind of answer this first question with a little bit of a story about the history of midwifery, of Indigenous midwifery in Canada, to kind of situate us a little bit. So I think a really critical part of the history of Indigenous midwifery in Canada, which I'm sure is similar in the case of Nicole and Ophelia as well, is the role that colonization has played in Canada in the decline of Indigenous midwifery. So the decline of Indigenous midwifery really happened through the outlawing and the denigration of Indigenous midwifery, and was an attack on our Indigenous knowledge systems, our ways of being, our ceremonies, and our practices that really extended into all aspects of our communities. The knowledge and the power of women was attacked as a way to control us and to assimilate us and to wipe us out. The control of Indigenous women through the at times violent control of our reproduction was and continues to be a tool of colonization. As recently as 2017 in Canada, we have official reports of Indigenous women being forcibly sterilized. Colonizers, the Canadian state, and our current government try to assert their control over us through our ways of being and our knowledge systems, which includes midwifery. In Canada, Indigenous people face widespread systemic and individual racism. We see this in all aspects of our society. We see this in overrepresentation in the judicial system, in the child welfare system, in the alarming rates of violence against our people, especially our women and our girls and our gender diverse people. And we see this in the disparities in our health outcomes, in education, and in income. These are all continuations of colonization and our attempt to get rid of us. So at times, these efforts seem to be insurmountable and completely effective. The Canadian state has not been successful at their attempts at genocide and assimilation. This is why the return of birth to our communities is so important to us. Why Indigenous control of our knowledge, our practices, and our healthcare, and our education, and specifically of our births, is so crucial. In the 19th century, with the medicalization of birth, there was a decline of midwifery in Canada, almost to the point of non-existence. And as the story is often told, the reemergence of midwifery started as a feminist consumer-driven movement in Ontario in the 1980s, with Ontario being the first province to re-regulate midwifery in 1994. What this often told story leaves out is the reemergence of Inuit midwifery with the opening of the midwifery program at the Inuit Health Center starting in 1986. Because of our colonial history, even our reemergence is often missed. The reemergence of midwifery in Nunavik, which is located in northern Quebec, came from the demands and the activism of Inuit women themselves. The Inuit women in Nunavik wanted Inuit midwives. They didn't want to leave their communities to be flown to the south to give birth in urban centers alone, surrounded by people who didn't speak their language. They wanted to give birth in their communities with their families, surrounded by their knowledge and their teachings. And so this is what they made happen. They developed a community-driven, sustainable Inuit midwifery program that was the first in this country and that to this day has some of the best health outcomes in the world. While Indigenous midwives depend on and are thankful for the support of our non-Indigenous colleagues, we continue to see the erasure of our work. In 2014, 2 birth centers opened in Ontario. To this day, they're often referred to as the first birth centers in Ontario, but this ignores the birth center which has been run by Haudenosaunee midwives at Six Nations since 1996, 18 years before the other birth centers opened in Ontario. Indigenous midwifery in Canada has a strong history, yet it's often forgotten in our mainstream stories. In the early 2000s, the National Aboriginal Council of Midwives emerged as an organization representing Indigenous midwives in Canada. This was a center pin for uniting Indigenous midwifery voices from across the country. Our power comes from us joining our voices together to advocate for all Indigenous midwives. The coming together of so many different nations to work together for the health and well-being of our communities. We are Inuit, we're First Nations, we're Métis, we work in different models, in different settings, we work in different parts of the country. Often we're working under very different circumstances, but we all work together through NACM to support each other and to grow Indigenous midwifery for all. An important part of doing this work is NACM's partnership with other organizations. Our longest standing and strongest partner is the Canadian Association of Midwives. We really wouldn't be where we are today without this partnership and without their support. The growth of Indigenous midwifery also takes commitment from our non-Indigenous allies. However, this isn't a one-way partnership. The strength of our partnership comes from both organizations recognizing that this is a mutually beneficial relationship. Investing in this joint relationship and in each other is what strengthens the entire profession of midwifery in Canada. So one of the things we really enjoy about NACM and that really helps us is coming together and being in an Indigenous space and talking with each other about our similarities and our differences and working collectively to raise each other up. So I'm really happy for this panel and that we get to do this at a global level and think about how we can talk as Indigenous midwives and strengthen the global collective of Indigenous midwives.
Thanks so much, Claire, for your introduction. I think there are so many things, that when you start to think, for us, for example, like midwives in South America, there's so many things, like you mentioned, that this has taken a time, about how do we recover our knowledge, how do we fight for our representation, and how would we still have so many things regarding, violence in girls and women. So those things are still, even though we are not Indigenous, but we still have. So there are so many things that maybe we have to see. And as you said, how important it is to join our voices, to be together. So let's see what Nicole has to tell us about this introduction.
Tēnā koutou ngā kaiwhakawhānau o te ao me ngā hoa tēnā umanga. Tēnā koutou I tēnei ata, I tēnei ahiahi, I tēnei ahi pō hoki. Just, I guess, a welcome to all the midwives and all our friends around the world. And, we're all in different time settings. So I just want to ensure that I was including everyone in that welcome. I just kind of want to bring it back, and I share New Zealand and in particular Aotearoa and Māori midwifery. We share a lot of commonalities with our Indigenous sisters around the world. And so not to repeat that, but when we talk about Indigenous, Māori specifically don't say we're Indigenous, we say we're Māori, we say we're tangata whenua, meaning people of the land, because we have an affiliation to nature and we have affiliation to Papatūānuku, which is our earth, who cares for us, nurtures us, and it's our purpose to ensure that we keep her healthy, to keep our mokopuna, our children and our grandchildren healthy as well. And I kind of want to talk around the importance of having a Māori midwifery in New Zealand. And we know that having a Māori midwife with a Māori woman does support and reduce the inequities that occur in a way that, as a midwife, we're an activist, and as a Māori midwife, we almost have to be in a rebellion as well. So we're a rebellious activist to ensure that we advocate for these women. I know that we have lots of non-Māori colleagues who are actively supporting us and actively working towards us achieving, I guess, a way of self-determination. And this is, I guess, a huge obstacle for Māori in itself. You know, whānau are always telling us that they want Māori midwives. We know that the obstacles exist around having student midwives in kura or school, just making midwifery an attractive place to come, because Claire touched on a lot of the oppression that has occurred through colonisation over time. And so when you're told that you're nothing from the beginning, it's really hard to pull yourself out of that and then to think ahead. And that's part of our role as being a rebellious activist, is to support our whānau, our family, into the midwifery profession, to protect not just the profession, but to protect our families in a way that works for us. As far as history is concerned in midwifery, we didn't necessarily have the term midwifery. We had tohunga, and tohunga were, I guess, practitioners of traditional healing, and they were kind of like an earthy medium, and they kind of tread that line between the spiritual realm and then also the physical realm. And so what they believed was that if you were unwell, that means that there was an imbalance with nature, and there was an imbalance with or disharmony around you. So they would treat both the spirituality of that imbalance and then also the physical body. And so what we see now is a resurgence amongst midwifery in New Zealand, is resurgence, almost like a grasping to hold on, to rediscover these practices, from calling our babies into the world in our traditional language, from singing them traditional songs to encourage them to grow and to contribute to their people, you know, to bless them, to know that we are there for them and that they have a place, not just in our hearts, but in their community. And also just practices around, you know, avoiding interventions. You know, we know that there's a large return to introducing these practices, because we know that our families who are having increased intervention are then having poor outcomes. So what better way to reduce those interventions than to see a resurgence of our cultural practices? And we do have a lot of activist type midwives, because we see the importance of that for our whānaus and for our family, and the history of midwifery in New Zealand. We have in Aotearoa Māori Midwifery Organisation, and you know, we also have a professional organisation, and we have a regulatory organisation. There's opportunities there for us to work better together, to better serve the women that we work with, better serve the communities that we work with. You know, if we look at where there is a law that was enacted in 1907 called the Tohunga Suppression Act, that's our traditional healers suppressing their practice, which sent traditional healing underground, so into Māori communities, because it was then seen that Western medicine was superior, I guess, in a way. Originally, the intent around the Suppression Act was to suppress tohunga who didn't have the traditional practices. They were kind of, I guess, fake tohunga that would come in and ride that line, but there was no place for them there. But what it did do ultimately was to see the desecration, I guess, of our birthing practices. And so there's a really big resurgence at the moment. What I see is opportunities in Aotearoa for not just Māori midwifery, Indigenous midwifery, but actually for midwifery as a whole, is the grasping of the language. What better way to have cultural competency is to normalise our language in all things. You know, and we have seen many of the organisations starting to shift towards inclusive language, and also changing from the Treaty of Waitangi. So in New Zealand in 1840, there was a document that was signed between the Crown, the English Crown, and the Māori chiefs at the time, to determine how they would work together to ensure that the Crown, the idea behind it was the Crown would control their settlers and Māori would continue to do what they do. That's not what happened. Settlers then decided that they would enact a parliament, and then they went on, and we now have a current government. So what there is though is more organizations are now taking up the Māori translation of that treaty, which has implications for Māori and non-Māori. It's change, and the change is the hardest thing that anyone can go through. It's a decolonization process is taking up of this document, and a document that was accepted by our tupuna, our ancestors. So what I would like to see is a real commitment from the midwifery community around the normalization of our language, about an adoption of the language, because you can teach cultural competency all you want, but you're never going to get it unless you know the language. So I will leave it at that, and we'll come back to some questions. I hopefully will be able to have some more later, because I have lots to say.
Yeah, thanks so much, Nicole. Really, yeah. This is really nice where you're telling us, there's so many things so important. First that we should say, Maori midwife. This is so important, because as you say, we try to, colonize everything. So at some point, we also should think about that. How do we want to be called? I mean, in our language, in Maori midwife, atahuna. Yes, as you said. And of course, there's so many things also that to highlight. For example, you've been advocating for reducing inequities, that you also activist midwives, and with all this strength to go on, to really be there, standing for women. And of course, I think it's really nice what you share with us, that suddenly everyone is learning what's been there for histories, that, like paying attention to the baby, to the mother and their baby, when it's inside, singing, being close, all this traditional healing that, of course, at some point, and regular midwifery education, of course, is including all this knowledge that is an ancient knowledge. And of course, we should also share. So thank you very much, because you are really showing us how important it is, this competence, these cultural competencies, of course, including it in our curriculums when we are teaching midwifery. So, okay, thanks so much for this introduction, and let's go to Ophelia. Ophelia, what do you think, Ophelia? What do you want to say to us in these first words? Thanks, Nicole.
Good afternoon or good evening. Thank you for inviting me to be part of this panel. I am a traditional midwife for the last 31 years, and I am part of a Tzotzil community in the state of Chiapas in Mexico. I was learning about midwifery because I inherited that from my mother and grandmother. I'm a spokesperson of the Nitiching movement in Chiapas, which means the corn flour, and it started in 2014. Currently, we are 600 indigenous midwives and mestizos in the field and in the city. We are traditional female and male midwives, some with traditional training. We are part of this movement to be stronger and to fight to have a dignified job. We as midwives. And in Mexico, midwifery has existed even before we were colonized by the Europeans. The native people had a care system for life, taking into account life, which includes the spirit, social life, the body, and we midwives are inheriting this knowledge. Through time, the biomedical Western model is the one that was implemented in the Mexican population, devaluating other kind of taking care of health and life. In traditional midwifery and in original peoples, they were undermined and they were marginalized, and they were considered to be a second or third class population. And traditional midwives, we are facing many obstacles. For example, in many areas of the country, we are banned to attend births because the official healthcare institutions considered that we endangered the life of women. And also we are criminalized, and they make us responsible for maternal deaths. When we take some women that have complications into a hospital, we are mistreated, and they also mistreat pregnant women, and they do not respect their decision on who, how, and where they want to have their births. And previously, we would able to issue the birth certificate. of those babies that we receive, but now we are denied doing that. So those women that receive our care, they are conditioned. And traditional midwifery in Mexico has been here despite criminalization and going through exclusion policies. Indigenous women prefer to receive our services at home, accompanied by their family members in their own languages, with their culture. But and we carry out ceremonies to protect the newborn baby. We give some advice for them to have more babies or not. We deal with the spiritual and physical knowledge by the knowledge that we receive through dreams as part of our gift, and also as a service for our communities. So for us, pregnancy and the birth is not just an obstetric event, but rather is to be able to take care of the heart, life, and future of indigenous people, native peoples. In Chiapas, according to official numbers, 1 out of 3 births are attended by midwives. However, in the indigenous municipalities or locations, this proportion increases up to 100% in births. Between 2018 and 2019, and the Nichichi midwives, we receive at least 7,893 births with no maternal deaths in our hands. That is because we are able to acknowledge which are the obstetrics emergencies and to channel them on timely basis to a hospital. Based on all this ancestral knowledge, we have combined them by using medical practices that we have learned through different workshops and training. And we consider that to be something positive, but what we don't like is for official health institutions to have a clear standing with respect to traditional midwifery. They don't take us into account as part of the maternal and neonatal care. We know that we are there, but we are invisible. They do not listen our voices. We want to have a relationship with health institutions, but based on respect. We wanted to work along and hand in hand with the doctors, using the skills and knowledge of all of us as a team that will be supplementary to each other, where we will include professional midwives so that indigenous women will receive a timely care and respectful care during their pregnancy, birth, and after birth. And in traditional midwifery is another option that women should have, an option that cannot be only linked to poverty, but rather with a choice of women. Traditional indigenous midwifery is a system of care which is current, effective, and as also as something good for mankind that needs to be considered and preserved. Thank you.
Thanks so much, Ophelia, for your remarks, that you're really telling us so many important things that you're sharing with us regarding midwifery in Mexico. I mean, indigenous midwifery, of course, you've been struggling with all this, being marginalized, of course, being undermined. At the third level, as you said, of course, sometimes criminalized, but it's really, it gives us hope to hear that you're really saying that at this point, you're really showing that, of course, indigenous midwives are being there, that they're delivering, the birth at community level, and you don't have, any maternal death or neonatal mortality. And of course, because you're also working with ancestral, with your ancestral knowledge, combined with with training. And I think that's a really good way to move forward, because being trained, but of course, maintaining your ancestral knowledge, it will really help to move forward and to help women and babies at this local level. And of course, that I really do agree, because of the experience of being there with you in Mexico when I was an ICMBOR member, that traditional midwifery should be there, should be a choice for women. And of course, you can both work together, traditional midwifery and of course, non-indigenous midwifery. So I think it's a really important key aspects that you really highlight. And so the next session, I mean, the next part of the session, we're gonna be discussing some really good questions regarding Indigenous midwifery. And I want each one of you to answer, the first question, that is, what has been the impact of the past and present health service policies and models of maternity service delivery on Indigenous mothers and their families? You already told us about your experience, what is going on in your country, but these questions want you to show us, to tell us what happens when you receive these comments of what is going on, regarding the experiences of Indigenous mothers and their families when they're going to the maternity services, with regular models. So we go ahead again with Claire. Claire?
So I think one of the things, I think there's lots of things that I could talk about here, and there's listening to Nicole's opening and Ophelia's opening. I just think there's just so many similarities between, like, even though we're living in different parts of the world, I think there's so many similarities to the experiences of Indigenous women in all of our communities. So one of the things I wanted to talk about specifically in Canada is, even though I think there's lots of policies that I could talk about, I want to talk about a little bit about the evacuation policy, which is what Karen Lawford, one of our Aboriginal midwifery scholars, talks about as an invisible policy. But this is the idea that women and a lot of Indigenous women who are living in Northern Canada have to come to the South to have their babies. So they're having to leave their communities around, like between 34 and 36, around 36 weeks, to come to urban centers, to stay here for weeks, often by themselves, before they then go to a hospital, again, often alone, not always speaking the same language as the care providers in the hospital, in a very different place and far from their home, and a different culture and different surroundings, to have their babies, and to have to do this at such an important time, and to not be surrounded by your family and your knowledge and, like Nicole said, your language and your people, is so difficult, and is something that has been really affecting the health and well-being of not only the women who are coming and giving birth, but also of their families who they have to leave behind, who don't get to see their family members be born, who don't get to have birth be part of the community. And not having Indigenous midwives in our community means that women are having to leave and go somewhere else, or not be surrounded by their culture while they're giving birth. And this has had detrimental effects on our health and our well-being. And I think it's, one of the things that we talk about a lot in Canada is this colonial conception of risk, right? And how we think about risk. And for so many people, the idea of having your babies, out of the hospital or far away from C-section capabilities or not with a doctor is seen as risky. But for so many of our Indigenous people, the idea of having birth away from your family and not having your language and not having your traditions and not having your knowledge respected is what is a risk. And having our births outside of our communities is a risk, not just to ourselves, but also to our communities.
Can I just comment on that, Claire, just in regards to, I guess it's a form of violence. You mentioned the violence earlier when you first introduced. And, if we relate to the amount of, I guess, disharmony and upset that women around the world have experienced, are experiencing during COVID-19, and their inability to be able to have their closest family members with them during that time, that I guess it's a time of vulnerability, but this is a normality for women in these communities. And not only that, but they're separated from their families for a significant amount of time, not just for that one event, which is a very important event, but it's an accumulation of assault, I guess, and violence over time that continues that threat of oppression, and it's needs addressing, and more than addressing, and action. So that's probably part of the activism kind of in me speaking out about that. It's really disheartening, and I know I've heard of it before, but it still brings tears to my eyes just thinking about it, and thinking about that, how we advocate for women every day to ensure that they have those that are with them that will advocate for them in a way that suits them and their rights, and these women have those rights taken from them. It's
I totally agree with you also, because in some way for us, for example, for midwives, non-Indigenous midwives in South America, it's the same thing. Even, actually with COVID, we saw how invisible women were. We had in many countries in South America, COVID started in March, and just in April, May, at that point, midwives received elements of protection. Women didn't have their birth attendance to the clinics because they were closed. So there were so many things going on that weren't seeing women. So at some point also, even though of course midwives were there, and we were Indigenous midwives, but women and midwives were suffering the same. So at the same level, of course, all of Indigenous midwives have the same situations around the world, but of course, all midwives, and because we're women, we have so many things in common. All of us are, of course, advocating for women in the same way, and that's also a good opportunity for us, because that's what we really need, to be together, to be strong. So I think it's a very important thing to know. So how is it? And also, Nicole, can you give us an example of the policy health service policy in your country, similar to what Nicole just told us? Claire just told us.
Yeah. I did touch on something earlier around the Tohunga Suppression Act, but I just want to talk about experience that my grandmother had, and this is a policy that she was told back in the 50s that she wasn't allowed to have her children at home, whereas historically and traditionally they were birthing at home on their land. So at that time, she went in for her first baby, and she said it was the best experience of her life, obviously, because she was away from family. She was separated. Her father he is generally, I guess, the tohunga of the family, and would birth his grandchildren. So for the successive children after that, she tried her hardest to hide, I guess, pregnancies from the authorities, to try to stay on the land, and then she'd pretend she wasn't in labour, so then it was too late and she'd have to birth at home. So she did. She had 2 children in a facility, her first and her last, and all those children in between were all born at home, in the hay paddock, under trees next to the river, wherever she was when she walked away, so that no one would realise she was in labour and then take her into the hospital. So these are some health policies, I guess, in regards to birthing that women have experienced, and that wouldn't be just in New Zealand, that would be universal around the world, I guess, in a way. And these are what women are doing. They are finding ways to try and avoid going in and potentially, putting themselves at risk. Whereas if we had policies in place that supported them, regardless of the risk factors, so that we have appropriate caregivers providing appropriate care at appropriate place. And for that woman, appropriate place might be at home, even though in our medical minds we might think, well, actually she should be in a facility. But the reverse of that is she doesn't have any care. So that's a significant impact on our mothers and our families, is that hiding pregnancies, hiding, I guess, half-truths, telling half-truths to do what they want to do because they feel that they will be enforced into doing something they don't. And that's universal, I guess, to many countries. Yeah.
I actually totally agree also with you, Nicole, because, for example, in our side of the world, also we've been, learning, as you said before, and also as Claire said before, because in one way for us, felt really safe to be at the hospital, inside the clinic, so anything will go wrong. But of course, women are empowering themselves, and they want to decide. They want to maybe have their babies at home, and of course their newborns at home. But of course, that's a challenge for the ones that are not being trained before in these ways, learning, to maybe to find new ways, new philosophies, or of course, and on the other hand, having the government supporting this, because of course you can have the policies in place, but you need the support. You need the support of the governments, of the organizations, so all the women have access to it. Because sometimes, we can also see that in some countries, just a few group of women can have access to that because they have more income, but the other ones that do not have more income could not have a birth at home. So then there's so many things that we have to keep on working on. So when having these conversations, it'll also show us that we have to still, keep on advocating so all the women have access to the best quality of care. That would be by indigenous midwives and non-indigenous midwives. So we would be there, and learning from each other and supporting for each other, of course. Okay, so Ophelia, what can you tell us about this? Can you give us an example of a policy in your country that also is, affecting the way that indigenous mothers and their families have their birth?
Sí, pues hasta el momento.
Up to this moment, the hospital type of birth is the model that has been implemented in Mexico based on what I have heard with my colleagues. This happens all over the world. This is a way to decrease maternal deaths. However, in Chiapas, what we see as a movement is that model is not the right answer for indigenous women and their families. For starters, is because that birth care is not the right one. Also because health services are not sufficient, they are not timely, and they are very expensive for the indigenous families. And also because and to transfer all the births, even those that are low risk, to take them into a hospital, that would mean to have a saturation of health services.
Sí, pues otro aspecto importante es que hay
Another important aspect is that there is a big gap between the policies and maternal health programs and the real care that women receive in prenatal care. For example, that doesn't take place because there are not health institutions, there are no labs, ultrasound, or other things that can help to improve that care. Or also when talking about family planning, contraceptives are not enough, and sometimes women, they need to pay for those methods that they will use. So this is something forced, or they needed to inform women. And also,
okay, muchas gracias, Ofelia, por esta respuesta. Y ahora vamos a pasar a la otra pregunta, okay?
Now we will move to the next question.
Well, I think this conversation that we're having is really interesting, for all of us, and we're learning so much among all of us, And I think we have this second question that is regarding what has worked to change policy and improve maternity services for indigenous women and their families? Can you give us an example? What do you think that has worked? For example, what is working in your countries right now to put, these two sides of the coin, I would say, together? I mean, this really trying to to give the answer to what indigenous families or women want from the healthcare systems. Nicole?
Yeah, I just kind of on top of my head, I'm thinking about maybe in recent times, and we just already kind of touch on COVID, and because of COVID, there's been an increased awareness around equity and addressing equity for Māori in New Zealand. And so there is lots of funding, for example, around health research. There is opportunities for area health boards to implement Māori-based, not birthing practices, but Māori-based care that will benefit Māori. I guess part of that is around ensuring, though, that Māori at the helm of that, because it's, once again, we do not want to see non-Māori leading that and doing what they think is right for Māori, but actually it isn't. So we do have to ensure that Māori are there at the helm, ensuring that, one, that we're addressing it appropriately for Māori women, because there is a common thread in New Zealand is that we say what's good for Māori is good for everybody, because if you can reduce the inequities for Māori, then you're going to improve the health of everyone, and regardless of their background and regardless of their ethnicity in New Zealand, because we do know that with our treaty that we do have in place, that we have a real hard commitment by the government, by everyone, to ensure that equity is addressed. Now, I use that word addressed quite loosely, because you can address it, but you need to action those things as well. So it's really important that any policies, and the other thing around policies, I have a hard time accepting the word policy. I think that's just my activism again, because it's a way of enforcing something. So we remove that. It's around autonomy, ensuring that our women have a right to make decisions that are right for them, and they have a right to enact their own consent when it is right for them, and they have a right to be. So any policy changes, any improvement to maternity service need to be Māori-led, and they also need to ensure that they address the autonomy, yes, for the midwifery profession, because we are working with women, we're women-focused and we're women-centred, but we have these policies in place to Māori, to make the policies to protect Māori from non-Māori influences. Guess that's kind of what I'm saying, because we know that non-Māori influence in the past has done harm. So how do we move past that? And we do have lots of non-Māori working really hard and really committed to that change, and they know that they need Māori at the helm, but there's so many few of us, and that's part of the policies, and that's part of the, I guess, changes that need to happen in maternity services around workforce development, ensuring that we have appropriate mix of workforce and Māori midwives. We need Māori midwives, we need Māori researchers, we need Māori educators, we need it all. So we need to get on making babies, and we need to get on making healthy babies. So
thank you, Nicole. Okay, what about Claire? What do you think about this question, Claire? What is an example?
So, I mean, I think my example is going to be, I think, very similar to Nicole's and similar to things that Ophelia has been saying, right? Is like, we need more Indigenous midwives, and because we need Indigenous people to take care of our Indigenous communities. And I think one of the things that I think about when I think about changing policy is like changing the whole way we approach care, right? And changing, and like it can't just be these like small little level changes. We have to make big changes, because we're talking about trying to bring two different worldviews together, right? A Maori, a Lenape, a Haudenosaunee worldview with a colonial worldview, which just doesn't fit together. So trying to think about like big changes. So what I think about a lot in terms of is like really care that is rooted in our communities, and that really starts with our communities, and looking at what each specific community needs and building care around that. And I think that's one of the reasons why Indigenous midwifery in Canada looks so different depending on where you are, because I use Indigenous because we're so many different nations in one country, and we have lots of similarities. We also have lots of differences, right? So the Inuit midwives working in the north look very different than the Haudenosaunee midwives working in the south, or the Cree midwives, working in urban centers or in different places. And I think why it looks so different is because we start with our communities and we say, what do you need? And you tell us what you want from your midwifery care, and that's what we'll do.
Thanks so much, Claire. And let's hear Ophelia. Ophelia, ¿puede darnos un ejemplo de una actividad que haya mejorado? Solo un ejemplo.
¿Sí?
Sí.
Bueno, pues en Chiapas y México, pues
In Chiapas, in Mexico, for the first time, I will mention this, which was critical for Chiapas, and that is in 1994, we had the Zapatista movement that emerged, and to make racism evident and to show the problems that the natives people have been facing to reivindicate the identity and pride of those people, and also by making that report of the deficiency of the basic services such as healthcare and education for those peoples. And another part is the contribution of civil society organizations that have made that situation of indigenous people visible, and they have helped to spread out the discourse of the right of indigenous women and the rights of midwives, the relevance of women's health and the role of midwives.
So we are going to move next because we have not many time, not that much time. So we have 2 questions left. But you know, this conversation is so interesting that we could be talking the whole day. I think we forget that we're so far away one from each other, but it feels like home. So we have 2 questions more. One question is, what is needed to develop and expand culturally competent maternity care for Indigenous women in your countries? What do you think that is needed to expand culturally competent maternity care for Indigenous women in your countries? Claire?
I don't need to go first. Somebody else can go first if they, I went first twice. I just want to make sure everybody, I can go though if we really want me to. Okay. I mean, I think I kind of talked about it already. Is more Indigenous midwives is really what I think that we need, and that you know, one of the ways that we can that we're really focused on doing that at NACM is to increase the Indigenous, increase access to education. So whether that's through university-based programs, making those more accessible to Indigenous students, and making sure that they, you know, are learning the things that they need to learn and that are important to them as future Indigenous midwives, or whether that's, you know, expanding and growing on the number of Indigenous community-based programs that we have in Canada. Our real focus on trying to build more Indigenous midwives is by strengthening our education programs.
Ofelia, ahora es su turno.
Sí, pues para nosotros es necesaria una profunda y seria crítica.
We want to have serious criticism made to the biomedical model. Also to consider that it has been a patriarchal and racist model. And if that is not being modified, and if they don't change that, then they would not be able to respond to the needs of women from Native peoples in Mexico and around the world. And specifically about traditional midwives, they would be used to use official policies. And we also need for health institutions to acknowledge traditional midwifery as a system of valid practices and knowledge and useful and required to keep maternal health. And also for the training of nurses and doctors, for them to know these other health care systems and for them to value it fully. And also to promote a horizontal and teamwork among doctors, nurses, and traditional midwives. And also in this multicultural perspective, we need to have health practitioners that will be speaking local languages.
Okay, muchas gracias, Ofelia. What do you think, Nicole? Do you agree with Ofelia?
I agree with all those things. So I guess I'm just going to summarize into 3 things. I guess speak no evil. So language is really important. Language that's woman-centered, language that is family-centered, and also the language of the native peoples. Hear no evil. So listen to what the people are saying. Don't listen, put it on a piece of paper and then put it in the back cupboard. Actually enact those things. That's the hear no evil. And see no evil. So restructure higher learning facilities, restructure into a way that's more culturally appropriate. For example, in New Zealand, move away from the traditional classroom settings and then come into more of an informal environment. So we have traditional meeting houses. Every directorate in higher learning should have their own meeting house, and then learning should be appropriate in those places, because then you're more likely to address speak no evil, the language, and also listen. So what better place to do that than those 3 things? And I think, and I say no evil because it is for the Indigenous people of New Zealand, for Māori, for tangata whenua, it is to them and to their health, it is evil. So we need to move away from that. So language, restructure higher learning facilities, and listen to what they say and enact it.
Thanks so much, Nicole. And finally, with just one small word, one small piece of words, I would like to ask you, what do you think what have you been doing to raise the representation of Indigenous midwives in your country? That's specific. How do you make Indigenous midwives be heard in your countries? Ofelia? ¿Cómo hace en su país que las mujeres sean escuchadas, las mujeres indígenas? ¿Qué hacen?
Sí, pues a las parteras queremos que sean incluido
We
únicamente.
want for midwives.
A ver, permítame tantito. Bueno, más bien durante en las parteras solo están incluidas en las
Midwives are only included in health policies, but
como pensado más hacia sus culturas, por ejemplo,
they don't think about their cultures. For example, they
Y
are only getting
Ofelia,
trained for their certification.
Ofelia, pero en su país, por ejemplo, están participando en la asociación, por ejemplo, con las parteras, con una asociación de profesionales, con la APP, la Asociación de Parteras Profesionales, la AMP,
pues,
Asociación de Parteras Mexicanas.
Pues aquí en Chiapas, en este momento, no hemos tenido.
We haven't had a close relationship with them, working with the Alliance of Midwives. But as a movement of midwives, we have been including more traditional midwives here in Mexico so that they can have more voice and more participation, and also for them to be acknowledged, or to acknowledge the work that they're doing in their own communities.
Okay,
it is very important for them.
Traducir. Okay, Ophelia is saying, I was asking her if in which way they were, trying to support for the midwives, Indigenous midwives, to be heard, to have more representation. She said that they are included in the movement, in the midwifery movement, but they are not really working closely to the associations yet. But she's right now she's saying that that's what they're doing. Okay, what are you doing, Claire, in Canada, to have more Indigenous midwives representing your voice?
I think I was thinking of something that Ophelia had said about just the recognition and the working with other healthcare providers and the recognition of our work as Indigenous midwives. So one of the things that NACM has really taken on is, there wasn't a lot at the provincial and federal level around policy. And so we've kind of really taken this on and really trying to promote what is an Indigenous midwife and what it is that we do and what do we do differently and how do we work in a way that other organizations can kind of understand it. So one of the things that we did most recently was put together a core competency framework for Indigenous midwives. And we did it in a way that we brought together all the midwives from across the country came, and we talked about what it is we do similar, what it is we do different, and we made it in a way that was useful to us and that communities could pick it up and say, okay, this is what I can use to say what a midwife is. This is what I can use to start thinking about how do I train a midwife. but in a way that it could go to different communities and be shared, but also in a way that policymakers and educational institutes and regulators could also look at it and say, oh, I recognize this document. I know what this is. And so I think that's one of the things that we've done that's been really useful in promoting what it is that we do, and really promoting a respect for our skills and our knowledge.
Okay, thank you, Claire. Nicole?
Yeah, so I guess the way that we've approached it is a number of ways, and largely a number of Māori midwives, because we have a different model of care in New Zealand where we have an employed and a self-employed model. But particularly around the self-employed model, you'll find that a lot of Māori midwives will take high school students out with them on work experience. Like, we're actually out on the street, beating the street, trying to recruit our own families and ensuring that what we'd like to see is every family group has a midwife, because we believe that our pepe or our babies should be in the presence of their own when they're born, to stop that process of colonization. So we get out there, we beat the streets, we work with students, we get them early and we encourage them. So even if we're working with families in the home, you become the family midwife. So you might end up with 5, 6, 7, 8, 10, and then their cousins and then their friends. So you start to, I guess, develop a relationship. We also have, Māori health providers, and they're based on family groups as well. And we have a way in which we encourage students to access scholarships, financial scholarships, to support them into higher learning. And then some areas do it better than others, is supporting those Māori midwifery students through their studies, because their studies are currently obviously not in a culturally appropriate model currently. So we are hoping to change that, or work towards changing it. So we are working with them to push them in to accessing finance, because we know that the study is really intense. So the work we're doing is kind of on the ground level. It's very on the ground level. It's not high level. There is high level work going on, but it's the documents kind of get regurgitated and they look the same year after year. So what we're doing is we're actually just getting on the street and working our way through as many families as we can to recruit them to midwifery, or into health at least. But
that's a great way to do it. Thanks so much, Nicole. So really, this conversation has been amazing. Has been really wonderful. All this, we could be talking the whole day, I'm sure. But now we have to go to Sarah, because we have to go to the questions, from the audience. Is Sarah there?
Yes, yeah. I'm here. Sorry. Just getting my video back on. Thank you all so much for all of that. As Sandra said, we could continue for hours, but we don't have a lot of time and we have a ton of questions. So what I'm going to do is ask Claire, Nicole, and Ophelia, if you put your microphones on, I'll ask the question and then you can jump in and we'll try to tackle as many questions as we can in the remaining 15 minutes. Okay, the first one was a question for Ophelia, specifically about Mexico, but I think it's applicable in Canada and New Zealand as well. So let's see. This was for Ophelia, you can start this one, but is there an opportunity for collaboration among midwives across states and across Indigenous groups in Mexico? So we've talked some about collaboration, but now talking about collaboration between Indigenous groups in different areas within your country. So Ophelia, if you'd like to start, then Nicole and Claire, you can jump in afterwards.
Pues aquí en México, pues hay muchos grupos de parteras.
In Mexico, there are many groups of midwives in different states, and each of them work in their own locations, and they have a different way to understand their culture. But also, we are trying to find out how to work together. That is important for us, to see the work that is being done by other midwives. For example, we are working on a national agenda that will help us to work together with the traditional midwives. For us, it's very important in Mexico to do that, to have traditional midwifery existing for a longer time.
Thank you, Ophelia. My Spanish is very elementary, but through the part of the translation, I did get that you were saying that you're trying to work together across several different areas in Mexico, and you're working on a national agenda currently to help midwives across Mexico to work together, even though there's a lot of different, there's a lot of diversity within Mexico, there is current efforts for collaboration. Claire and Nicole, do you have anything you would like to say regarding your own countries?
Yeah, if that's okay, I was gonna say we have, you know, we also have in Canada a lot of difference in our Indigenous populations, and I think that's one of the real strengths of NACM is that we've all, you know, as you can see even on this panel, right, we're from so many different places, and there's so many shared histories and shared ideas and worldviews. And so that's what we've kind of tried to put together at NACM, is to bring us together and talk about like what is similar and what is different, and how we can support each other. And there's so few of us in Canada that it's, you know, for us, we have to come together to support each other, to be able to work together and really collectively raise us all up.
Yeah, New Zealand's a lot smaller than, you know, we are a small community, and then the midwifery is a smaller community even then. And the collaborative work is ongoing. We do have different iwi groups, which is different family groups. But as far as collaboration, we do have an organisation who supports the interests of Māori midwifery and traditional birthing practices. And they're working hard on ways in which we can work together with not just within Māori midwives, but also with our other national bodies. So I guess you would think it'd be easier because we're smaller, but no, there's still lots of challenges that we face just in the traditional practice differences even. So yeah. Right.
Thank you. Okay, so now I'm jumping to a new question, and I think, you know, you can all speak to it. And as we go through these, if there's questions that you don't want to speak to, that's also fine. I will just take a clue if you don't actually start speaking. So here's a question. Are there concerns about appropriation of Indigenous care practices? And have there been sensitive and successful adaptations and adoptions of your practices?
That's a good question.
Mm-hmm.
I guess the simple answer would be yes. So with part of the resurgence is opportunities for business, and using business opportunities to sell traditional practices with the movement towards, not saying that it's trendy or it's popular, but that resurgence towards us. And because there's a loss of knowledge on how to make or how to prepare different medicines, or you know, how to practice different practices, it's being used as a business opportunity to sell it, rather than an opportunity to educate and relearn the foundations of that practice. So yes, there is.
I would agree. I'd say the short answer is yes. And, you know, I think a lot of times people can mistake cultural safety and cultural appropriation, right? And being a culturally safe healthcare provider doesn't mean you try to be an Indigenous midwife, because you can't do that. And, you know, so I think the best thing for us is to have Indigenous midwives and to have midwives from our own families and our own communities. But until we're at that point, cultural safety and being safe for our families and our women and our pregnant people is important. But that doesn't mean trying to be an Indigenous midwife. It means respecting our families and our traditions and our ways of being and knowing, not trying to replicate them.
Sí, pues nuestra cultura, pues sí ha habido algunos cambios, pero
in our culture, we have had changes, but that doesn't mean that we lose our culture. Also, our training as traditional midwives is very diverse. We received the gift of being midwives, but also we have had some changes that improves care for women, because we pay close attention to women's health to avoid their deaths and to avoid infants' death. But that doesn't affect us as women. But we don't want to have something imposed on us. We want to do something that will really improve healthcare. And also, we always insist on having the recognition of traditional midwifery, because that's something that has existed in our communities, and we are the first contact with women. And that is why it is so important to keep up with the traditional midwifery in Native peoples.
Can I say something to that?
Please.
Okay. You know, I think that sometimes we have this idea that being traditional means you don't change. And like respecting our traditions and our knowledge doesn't mean that we don't also provide really excellent care and stay up to date with medical changes. It means we're trying to figure out a way to bring these two things together. And, you know, when you're providing care to your community, of course, you're concerned with getting the best possible healthcare that they can get. But what I think we all recognize as Indigenous midwives is that part of that is tradition and Indigenous knowledge. That is also an important part of healthcare.
Absolutely, thank you. So I'm going to move to another question. We only have 5 minutes. So what I'm going to do is I'm going to leave you with this one kind of combined question, and then also ask you if you want to give any last remarks. If there's things that you really wanted to say today and you didn't get a chance to, this is the time, because this is the last question. And you can just answer very quickly to my question and then go into your own. But I have a question from Ethiopia about experience in midwifery practices in your country, working specifically with adolescent girls and on sexual reproductive health services for adolescents, and what has that experience been? That's one part. The second came from Tanzania, asking about if you work in nutrition when you're working with women, depending on, she was talking about how mothers are often malnourished and culturally asked to eat last. And do Indigenous midwives or midwives practices in general work with women on nutrition? So those are the two aspects, the adolescent sexual reproductive health and nutrition components for your practices. And then also any final things you'd like to say.
No one wants to go.
No one wants it to end.
Sorry, what was the second part? Adolescent health and
then nutrition.
Nutrition. Yeah, I guess there was the mention that in some cultures there was women eating last. I believe that was part of the question, was it? And I guess that comes back to part of different cultures. So we're all different. In Māoridom or in Te Ao Māori, this mother is in a protective space. She has a protective space and she's protecting the future of her people. So she doesn't eat last. And I guess that's probably hard for me to be able to comment because I don't live in that world. But what we do address though is poverty. We do have extremes of poverty and women not eating just by circumstance and not being able to afford foods, which is probably experienced universally amongst all of us. Women having working with women in poverty and around. So you find different ways because there's an expectation that the westernized food, for example, is kind of the go-to. So there's a reversion back to trying to encourage families to grow their own food, to reversion back to trying to do the hunter-gathering, which is easier in rural communities, a lot more harder to deal with in cities. And different midwives here have different ways in which they deal with that. So we do have opportunities for food banks where we can access food, but that's it's a short stop measure. It's not a big measure. And I mean, that's a really challenging question. And I don't think we could answer that today, but it might be something that we can look at addressing you know, maybe at next IECM, whenever that happens. Yeah.
Claire or Ophelia?
Sí, pues las parteras tradicionales siempre
Traditional midwives have been always been working of providing advice to prevent pregnancy in teenagers. That has been very important because teenagers' pregnancy has contributed to a high number of maternal deaths. So traditional midwives are the ones that have been acting as advisors because they know their own community and what women need. And besides that, during pregnancy, they provide advice of the importance of nutrition. So they can avoid having problems during pregnancy. For example, a woman who is pregnant, she might have some complications or birth or after birth. So nutrition is key. Another thing that we deem very important to mention right now is that midwives during COVID have been there attending women during their pregnancy and after births. And during this pandemic, no woman has died because midwives have been there in the front line, despite the fact that medical services have closed some institutions, but midwives have worked constantly, and even though some midwives stopped working because of health issues, but we can see what is the relevance that midwives have, and this is something that has not been recognized officially.
It's the same for us in South America also, you know, because midwives are, we work through the whole cycle. We also work with teenagers and family planning, gynecology. So we've been there for women. We haven't left them alone, even though some hospitals and clinics have closed. But of course, as Ophelia said, women and midwives have been invisibilized. So we were there just, fighting really strongly to make our voices heard, just like Ophelia said.
Wonderful, thank you. Nicole, do you have a last comment?
I do, and I just, because I didn't mention around the young mothers, can I just say that in Māoridom, in Te Ao Māori, that young mothers is not abnormal. That's actually a normal process of life, and it's accepting what is abnormal is the way in which they're treated. So they, in our culture, that they absolutely have every right to become mothers and be treated respectfully.
Wonderful way to end. Thank you, everyone. I have learned so much, and I'm sure our viewers have as well. And I really thank you for all of the efforts you have put into making this event happen. As I've said a couple of times, we are in many, many different time zones and countries. And I know we were working on a lot of different technology. So thank you also for your patience with the translation. Thank you, Sandra, for moderating. Thank you to the panelists. Thank you again to UNFPA and the International Confederation of Midwives. In the next few hours to 24 hours, there will be the live webcast. It will be up and you can rewatch the event at that time. We will also, in the next few weeks, we'll publish an event summary, and we'll also create a podcast from this event that we will publish on our blog column, the .mom column, which is on New Security Beat. And then coming up, we are collaborating again with the International Confederation of Midwives and UNFPA to bring more Indigenous midwives into the conversation through a series of podcasts. So that will be happening in the next few months. And then in December, we're hosting another event in our Year of the Midwife series with UNFPA to help launch their upcoming paper on the impact of midwifery that has been done in partnership with the International Confederation of Midwives and the WHO, the World Health Organization. For now, thank you all again. Thank you all of you for watching online. I hope you enjoy the rest of your day or your evening. Thanks for joining us and stay safe.